All right, let's dive right into a medical detective story. It's about a problem that is, way more common than you'd think. You go through a big knee surgery, you do the rehab, but months later, the pain's still there. Or worse, it's a totally new kind of pain. Today, we're going to investigate a hidden culprit that's finally being brought into the light. Yeah, this is the million-dollar question, isn't it? On paper, everything looks perfect. The surgeon says the new joint is in place, the scans look clean, but your knee's screaming at you. It's this burning, zapping, electrical pain that makes no sense. It's a real puzzle, and it leaves a lot of people feeling completely lost. And get this isn't some rare one-in-a-million thing. Studies show that up to a quarter, 1 in 4 people who get a total knee replacement end up with this kind of persistent pain. That's just a staggering number of people who went through a massive surgery hoping for relief, only to be left asking, what on earth went wrong? Okay, so here's our game plan for cracking this case. First, we'll look at the core problem. Then we'll zero in on our main suspect, a tiny little nerve. After that, we'll see how doctors play detective to confirm the diagnosis, check out the treatments, and finally, look at a really cool new non-surgical approach. All right, let's start with section 1. This whole mystery begins with a huge contradiction. The very surgery that was supposed to get rid of the pain has, for some people, created a whole new baffling problem. The best way to get your head around this is to think about your body's electrical wiring. So, the surgery did a great job fixing the big mechanical parts of the knee. But imagine if in the process, a tiny little sensory wire got nicked or trapped. Now that wire is just short-circuiting, constantly blasting these false pain alarms to the brain, even when there's no real reason for it. That, in a nutshell, is neuropathic pain. Which leads us to our next chapter, finding the hidden culprit. So, if it's a faulty wire, which one is it? Well, in a lot of these cases, the evidence points to one prime suspect, the infrapatellar branch of the saphenous nerve. I know, it's a mouthful, so let's just call it by its initials, the IPBSN. So why this nerve? It's all about location, location, location. As you can see here, the IPBSN runs right across the front of the knee, exactly where surgeons are making incisions. Its only job is to provide sensation, to feel things, and its path puts it right in the line of fire during a whole bunch of common knee procedures. So what exactly happens when this little nerve gets damaged? Well, a couple of things can go wrong. It can form something called a neuroma. You can think of that like a frayed, angry bundle of nerve endings that's just firing off pain signals randomly. Or it can get entrapped, which is basically when scar tissue forms around it and glues it in place, constantly irritating it. And check this out. We can actually see the evidence now. On the left, you've got a diagram of a nice, clean, healthy nerve. But now look at the ultrasound image on the right. See that dark, sickened, lumpy area? That's it. That's the neuroma. That's the physical source of the pain that we can finally visualize. Okay, so we've got our suspect. How do doctors actually prove it's the real culprit? Well, their investigation comes down to collecting 3 key clues. It's a pretty methodical process. It starts with a hands-on physical exam. Then they bring in the high-tech ultrasounds to literally look for that frayed wire. But the final piece of the puzzle, the real smoking gun, is something called a diagnostic nerve block. You put all 3 together, and you can solve the case. This third step is the absolute moment of truth. A doctor uses the ultrasound to guide a tiny needle right to that irritated nerve and injects a little bit of numbing medicine. If that chronic, nagging pain that's been there for months or years completely vanishes for a few hours, bingo. You've just confirmed that the IPBSN has been sending all those false alarms. And that confirmation leads us right to our next section, closing the case. So once you know for sure that the IPBSN is the problem, what do you do about it? This is where the evidence gets really compelling. This data right here is what cracks the case wide open. Just look at the difference between the responders, the people whose pain went away with the block, and the non-responders. It's just night and day. A whopping 97% of the responders had visible nerve damage on their ultrasound. The other group, only 6%. The evidence is just overwhelming. And this chart just makes it crystal clear. The responders saw their pain plummet from an average of 6.5 all the way down to nearly 0. Their pain just poof, gone. Meanwhile, the non-responders barely felt a thing. It's just an incredibly powerful diagnostic tool. So what about those non-responders? Well, the investigation isn't over. As the researchers point out, if the nerve block doesn't work, it's a huge clue that the pain is coming from somewhere else. A lot of the time, the real problem is something mechanical, like the joint itself is unstable, and that requires a completely different fix. It really shows why getting the right diagnosis is everything. For the people who get that confirmation, there are a couple of main paths forward. You've got the surgical option, which is where they just go in and remove the damaged part of the nerve, and then you have less invasive procedures like something called cryoneuroablation, where they can actually freeze the nerve to stop it from sending pain signals. Pretty cool.
But hold on. What if you didn't have to block the nerve or cut it out? What if you could actually heal it? That brings us to our final section, and it's a look at a new non-surgical option that's showing some incredible promise.
A recent case series explored a totally different idea. They injected a material derived from amniotic and umbilical cord tissues. Now, why would they do that? Well, because this stuff is loaded with natural biological signals. It's basically a repair crew in a syringe. It fights inflammation, prevents scar tissue, and sends a powerful message to that damaged nerve to start healing and regenerating. And the results they saw were just jaw-dropping. These patients started with an average pain score of over 7 out of 10. Then, just 6 weeks after a single injection, their average pain was down to almost 0. We're talking about a near total reversal of chronic, debilitating pain. And this isn't just about numbers on a pain scale. I mean, just look at these photos. On the left is a patient's knee before treatment. It's swollen, it's clearly painful. And on the right, that's the same knee just weeks later. The swelling is gone. This is more than just pain relief. This is about getting your life back. So let's wrap this investigation up. What are the key clues for you? Number 1, that burning electrical pain after surgery isn't normal and it's not something you just have to live with. 2, it often has a very specific cause, that little IPBSN nerve. 3, there's a clear diagnostic path to find out if that's the issue. And finally, once you have that diagnosis, there are real, effective options, including these amazing new regenerative treatments. And that leaves us with one last big question to chew on. We've been talking about knees this whole time, but nerve irritation can happen in all sorts of surgeries. So, could this same detective work, find the nerve, prove it's the culprit with a block, and then treat it directly? Could that be the key to solving countless other types of chronic post-surgical pain? It really makes you wonder. The investigation definitely continues.